All right, good afternoon, everyone. We're going to go ahead and get started here. Thanks so much for joining us for the No Surprises Act Key Components and Operational Considerations webinar. I am Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. A couple of housekeeping items before we get started here. This webinar is being recorded and it will be available along with a copy of the slides on our website at lrha.org. Your lines are muted to prevent background noise, but please feel free to enter questions into the Q&A box and we will address those at the end of the webinar. After the webinar, we also have a brief survey that should automatically open into your browser, and we do ask you to please complete that, survey so that we can continue to improve our future events. And so with that, I would like to welcome Amy Tepp, partner in charge of revenue cycle at Eide Bailly. Amy works out of the Minneapolis, Minnesota office of Eide Bailly and oversees its revenue cycle services within its healthcare consulting group. Amy has more than 30 years of experience in healthcare finance, leadership, reimbursement, revenue cycle, pricing, and compliance. She has worked in the capacity of medical auditor, director of reimbursement, revenue integrity, and regulatory review and analysis, a compliance officer, and consultant. Thank you so much for being here with us, Amy, and I will hand off to you for the presentation.
Great, thank you. I'll just move on to the objectives. And today we're going to talk about the No Surprises Act. And hopefully for most of you, it's not a surprise. You are aware of the act. I'll just share a few little statistics. I was at the Healthcare Compliance Association Annual Compliance Institute a couple weeks ago and sat in this type of a session that it was talking about the No Surprises Act, and they did a poll at the beginning of it. So this might help you kind of see where you sit with your organization's readiness and understanding of this. When they did their poll, they said there were 65% of those who attended feel somewhat confident that their organization is addressed, the compliance side of things with the No Surprises Act. 14% said that they feel very ready for it. 16% not so much, and 6% were like, what is the No Surprises Act? So you'll see where you fit in there. I just thought that was interesting information because I think sometimes you wonder, are we just the only people that are doing this, or where's everyone sitting? So we're going to talk about this No Surprises Act, the final rule requirements that became effective on January 1st of 2022. And understand what is surprise billing and the need for regulation. And we'll talk about some things for you all to consider as you're, working through the compliance components of this. And I just have a little note at the bottom of this slide. This information is current as of today, April 19th. And as we know, things change, and especially with this No Surprises information, and I'll talk about that more throughout the presentation, but things are changing every day on it. So just something that you're going to have to keep a pulse on. So let's just talk a little bit about the background and on the rulemaking. So back in December of 2020, the Consolidated Appropriations Act of 2021 was passed, and in that act was this discussion on surprise billing, which then morphed into this, it's called the No Surprises Act. There's a variety of what we call interim final rules. Those are things that didn't go through the regular formal rulemaking process, where if those of you who are familiar with how, when the annual outpatient PPS updates and the physician rules that come out every year, they go through a proposed rule process where you have time to comment, and then you see what they end up doing in the final rule. This just went right to final rule with comments. Everything around this act went to this interim final rule with comments piece. And the thought there was CMS felt, this is just too important that they just wanted it to get going. It was effective the 1st of January of this year. And throughout 2021, as you'll see, there were these interim final rules to help everybody get ready about what the expectations are around complying with the rule. So this first, part 1 of the No Surprises Act was issued in this interim final rule on July 1st of 2021. And it showed up in the Federal Register on July 13th. And it speaks to the requirements related to surprise billing for the Part 1. The No Surprises Act Part 2 was issued interim final rule on September 30th of 2021. It showed up in the October 7th Federal Register. And these again are the requirements related to what we refer to as the surprise billing Part 2. So let's talk about Part 1. Now, I've had a lot of experience reading proposed and final rules and such over the course of my career. And I have to say that reading this first interim final rule was very confusing to me. It was, I don't know, and anyone else who's done this has said the same thing. And part of it was I saw a lot of repetition. Well, then I realized, because what we're talking about in this Part 1 impacts, it only applies to those individuals that have insurance, not Medicare, Medicaid, not in the federal stuff, but like group health plans and group and individual health insurance coverage. So therefore, we have a variety of departments in the government that have a stake in the game, if you will. So, that's why I was reading things like 4 different times. So you have the Office of Personnel Management, because it relates to the federal employee benefit health plans. You have the Department of Treasury, because the IRS isn't, concerned about things in it. The Department of Labor, as it relates to the Employee Benefits Security Administration. And the one that we're most familiar with in healthcare is the Department of Health and Human Services, as it relates to the Public Health Services Act. That Public Health Services Act goes back to the ACA of 2010. So as I mentioned, this Part 1 deals with participants and beneficiaries that are enrolled in group health plans and group and individual health insurance coverage. And it protects them from surprise medical bills. And we'll talk a little bit more about that in a bit. So as I tell people, and I think when this stuff first came out, people were getting confused. They heard good faith estimate. They think it applies to everybody. You have to really think about, what are we talking about here? And it might seem that I'm making this very simple, but it is very simple. But what the orchestration of complying with some of these things is where that gets a little complicated. So as it relates to these individuals in these group health plans, then we're looking at, what are we talking about when it applies? So it applies for emergency services that are provided both in a hospital and a freestanding emergency department, non-emergency services from non-participating providers, AKA out-of-network providers, that are performing services at a in-network or participating facility. And then air ambulance services for non-participating providers of air ambulance. So what is a surprise bill? This is an unexpected bill from either a provider or a facility. It's where the provider or facility provided care unbeknownst to the participant or beneficiary, that is indeed a non-participating or out-of-network provider or facility as it relates to their health insurance coverage. And this occurs and has historically in both emergency and non-emergency care settings. So the non-participating provider or facility does what we call balance bills for the difference. And the difference is between what that non-participating or out-of-network provider or facility receives from that your health insurance and up to the amount of the standard charge. So you can imagine that can be a significant dollar amount in some cases. And the other thing that is troublesome for people with this situation is that a lot of times that difference between their out-of-network payment that their health plan pays, that up to the bill charges, that doesn't go towards that health insured person's annual out-of-pocket cost sharing, the deductible type thing. So why are we talking about this? And and this is a bipartisan issue. As I say, there's not a lot of things that are bipartisan much anymore. We know price transparency was one of those issues that is very much bipartisan, but so is surprise billing. Both sides of the aisle agree that they don't want their constituents to receive these balance bills. So some of the information that was noted in the interim final rule spoke to some of the data that they looked at that drove to what we're talking about here today. So basically, 2/3 of adults worry about being able to afford unexpected medical bills. And 41% of adults with health insurance received a surprise medical bill in the previous 2 years. And there was something called the Box Project that reported accident victims receiving care at out-of-network hospitals received bills of over $20,000. And it was noted too that February of 2021, there were 33 states that had some surprise billing laws. But in some cases, CMS didn't really think that that was enough protection provided to individuals. Plus, it's different. And I know Louisiana has some surprise billing rules. Those are things that you're going to find out you need to be aware of, not only what federally is being talked about here today, but what your state requires as well. And then they analyzed claims data, which drove to the most common situations that happen where we have these surprise bills generated. The other thing that was noted is that 18% of emergency department visits result in surprise bills. And it oftentimes certain physician specialties are, have these surprise bills, and they're typically the ones that we don't actively shop for. Like, we're not shopping for our anesthesiologist or CRNA, and we're not shopping for our emergency physician. We just go to the ER and that's the doctor we see. So I've listed some of these specialties. This is driving them to where they're coming to on some of these requirements. Basically, these physicians have, not had to contract. They didn't feel a need to, and they a lot of times did do balance billing in order to, make up for the gap. They didn't contract with health plans a lot of times, which causes some of these surprise bills. 75% of air ambulance transports were out of network, is what they found in their data. And many providers of air ambulance are not associated with a hospital, and they don't participate in, being in network traditionally with health plans. They didn't have any incentive really to do so. And then it was noted, kind of like what I mentioned before about the $20,000 on average surprise bill from the previous slides. For air ambulance, it's $27,500. And I did have a conversation with the facility located in Alaska, and that CFO there confirmed, yep, it's not unusual for us to see $28,000 air ambulance bills. And I already mentioned about the fact that this out-of-network balance billing does not count towards an individual's deductible or max out-of-pocket limits. So, you know, the billing process under this is that you would bill the health plan to determine the amount the patient, to bill the patient. You would look towards state law based or this thing called the qualifying payment amount. We'll talk a little bit about what that is. The health plans are supposed to make an initial payment within 30 days of a clean claim, and they are not to deny for medical necessity or non-coverage. They can no longer look back to the final diagnosis to determine that. They must be looking to the admitting diagnosis or chief complaint. So this qualifying payment amount and cost sharing. In essence, you know, when we talk about non-participating emergency facilities and non-participating providers at non-participating facilities providing services there, there's a few different things. Now, the first one they talk about is this all-payer model agreement. I don't believe Louisiana is impacted by this. There's only 3 states that this applies to, and I'm pretty sure that it's like Maryland and Vermont, and there's one other, and I can't remember what it is, but you would know if you were part of this qualifying or this all-payer model. You know, if it's not this all-payer model, well then, is there something that's specified by state law? And if there is nothing really specified by state law, then it's the lesser of the bill charges or the qualifying payment amount. Now, when I say that, if the qualifying payment amount is higher than your bill charges, that's probably something else that you might want to take a look at. And you may have some issues with how your services are being priced from a competitive market perspective. And then the same thing would apply for the non-participating air ambulance. It would be the lesser of your bill charges or the qualifying payment amount, which I have in there a median contracted amount. That's what the term is. That's what the health plans are supposed to be paying you for this out of network going forward. And then this is just some information on how these things should be calculated, looking at some, you know, insurance and market types, similar items or services. You know, I think until we start seeing some things come through payment wise, we'll have to see if those payments look reasonable or not, that we're getting paid for these situations. You know, so then there's that logistics piece about this and communication as to how are we tracking this to see if we're getting paid reasonably for these types of services. If not, there is an independent dispute resolution process that I'll talk about in a minute here. So what do they mean by a healthcare facility? When we talk about a participating facility, when does this part 1 apply? So we're only talking about things that are provided in a hospital outpatient department, a critical access hospital, and an ambulatory surgical center. So some of the things that you need to do if you are if you're a critical access hospital or a rural hospital, you need to have some sort of notices that are provided to this population of insured individuals. And there needs to be some sort of signage put up in a prominent place, likely where you have other similar types of information posters, if you will, for your other things that you need to post within the facility, something on your website, and then the notice to the patient, which I just mentioned. And that's basically letting them know what their protection, that there's this No Surprises Act, and that they have these federal protections and state protections as applicable from balance billing or surprise bills in certain settings. Now, I have under the notice to the patient this thing that says agreements with providers. So if you have provider agreements, and the provider's supposed to be providing the patient with these notices, and the hospital's supposed to be providing these notices, the government says we don't need to do it twice. So you can have something written in those provider agreements that says, we're letting hospital so-and-so is going to provide the public disclosure notice to the patients. And we understand that if we find out that they're not really complying with it, that we have an obligation to report it. But that gets the provider then out of having to hand a notice out. And then the patient isn't getting multiple notices. The other thing that when you hear this section of it, there is this consent to waive balance billing protections. So in the first thing that I'm talking about, I'm telling you, oh, here, insured patient, here are your rights under this surprise billing, that you have protections under the law in these certain settings to not get a surprise bill. But if you're going to schedule something and you find out that that provider, the facility's in your network, but maybe a provider's not, if somebody who's part of that care is not, then you are offered, and the hospital would provide that patient with a consent to waive their rights under this balance billing protection. Now, if one thing I'm going to say at this point, and I do have facilities that I work with that are like, but we don't balance bill. It's not our practice to balance bill. And if you don't balance bill, well, this probably isn't something you're going to end up doing, this handing over consent to waive. But if it is your practice to do balance billing on out-of-network insured patients, then you would want to talk about, well, how will this work and what are we going to do for this process? To those who don't balance bill, what I would suggest is that you have a policy in place that says, it is not our organization's policy to balance bill for out-of-network in these situations. If we should find that we inadvertently balance billed somebody, that we will return that payment to the patient upon discovery. And as with any of this stuff, the public disclosure piece that I just mentioned, the waiver to the balance billing consent to waive form, and then something I'll talk about in a bit, which is the good faith estimate, they all have a timing expectation associated with when you are supposed to provide that to the patient. So I talked about all these interim final rules. Well, then in the middle of this, there were some proposed final rule or proposed rules. And this is a little really technical slide, but it was issued on September 10th and comments were due October 18th. And what that basically, the two things I got out of that piece is that, well, what they're requiring is air ambulance services now need to submit data to HHS. And so they need to provide information now on transportation and medical costs, the data on air ambulance bases and aircraft, the number and nature of air ambulance transports, payer data, claims denials, and then HHS and the Department of Transportation are to put together a comprehensive report for the public. The other important piece of this proposed rule is where they talk about the enforcement around not complying with this Public Health Services Act requirements around surprise billing. So it's extending CMS's existing processes for determining if states don't have something substantial in place. They look at it that CMS is able to enforce on this act. It creates a process for initiating investigations and determine non-compliance. It codifies the process for imposing civil monetary penalties of up to $10,000 per violation on providers, facilities, and providers of air ambulance services. And then it's up to $10,000 violation for any air ambulance service that fails to provide the data that I mentioned in the first bullet point under that reporting requirement. CMS may waive the civil monetary penalty if the provider unknowingly violates the requirements. If any of these bills and it was sent in error, and they realize that, once you found out it was sent in error, that you reimburse the patient within 30 days. So, as much as I've done this presentation, I find myself chuckling because I don't normally say how wonderful a website is on cms.gov, but honestly, if you haven't gone to this resource page, it's cms.gov/no surprises. It's something that you're going to want to keep a pulse on because it gets updated periodically and you don't really know it. And certain pages get updated. It doesn't just, the cover page might be dated February 28th, but in there somewhere else, there's a April 15th update. But I find this very helpful, and it gets updated as things evolve and change. It has a policies and resource section. It has the resolving out-of-network payment disputes, and then has a section for consumers. The policies and resource section, this is a place to go for all of these rules I mentioned. You can go in there and that overview of rules and fact sheets. It has all the fact sheets there. It's organized very nice. Talks about, how to submit a billing complaint, and so on. So now I'll just go in a little bit about what this overview of rules and fact sheet says. So this has all of the different interim final rules, and it also has the different fact sheets. These things get updated, periodically. The section that I find, very useful is the good faith estimate piece, and I'll talk a little bit more about that. But when this first, this rule came out in December of 2020, July of 2021, we had the part 1, October, we had part 2. CMS had nothing of a resource page, and they had like one webinar at the beginning of December on this. It wasn't until the end of December of 2021 that we actually had something with the CMS resource page. But I've noticed over the last few months, it's really gotten more organized and a lot more information added to it. Now, something else that I learned as I was looking on the web, going out there and looking on what's going on and updated, there has been a lawsuit, the Texas Medical Association versus the United States Department of HHS. And basically on the resource page is the actual memo that's issued regarding surprise billing protections, and what this lawsuit was. The Texas Medical Association actually prevailed in this case. And what it's doing is it's saying, well, their argument around this independent dispute resolution process for the Part 1 types of things where you have an issue as a facility or a provider with what you're getting paid, that process that's in the rule is now under dispute, if you will, invalidated. So specifically, what the department was told to do through this court case was effective immediately. They had to withdraw guidance documents related to the sections that were invalidated by the court. And then once updated according to the court order, they will update this individual pages. So that's why I think now I'm seeing, current updates, because they've gone through and worked through this, what needs to be taken out for now or updated. They also need to provide training on the revised guidance through some sort of webinars and roundtables. And this is for not only those independent dispute resolution certified organizations, but also for providers. And then they are going to open this IDR process for submission through this something called the IDR portal. And that IDR portal is was supposed to go live last week per the website. So what has not been impacted by this lawsuit and the result of it is that consumers are still protected from surprise bills in the settings that I talked about in the applicable situations noted under Part 1. And the patient provider dispute resolution process, which I'll describe in a minute here, for the uninsured and self-paying consumers still remains in force. And that's all around that good faith estimate piece. The next thing is on the website, they have these forms that are in disclosures I've been talking about. So something that they call the model disclosure is that one about the public awareness around this, making, the availability of what this No Surprises Act protection is, and how they want it displayed. So basically, there's a template on that website, and you're able to modify it however you want. The disclosures that are out there are pretty, they're written real nice. I feel that they're pretty easy to read and understand. A lot of facilities that I've seen have kind of just taken what those model disclosure things on the website are and just updated for their facility and some of the contact information, and then updated for whatever state applicable no surprises type things may apply. So this is talking about, you need to put that thing in a public area that people would see. Generally, most of the people would come in and see, and you need to have something noted on your website that's prominent and easy to find on your home page. And then you need to provide a one-page notice that's in clear language, talking about the restrictions on providers and facilities regarding balance billing in certain circumstances, the state laws, and then what the contact info is for federal and state agencies should they have questions about it or have some issues that they want to talk to somebody about. this is just more information coming off of that website about some things, that apply to this. Use of plain language, again, for this model disclosure. It needs to be one page, double-sided. They even tell you what type of font it needs to be in. And then at the bottom, I think it's important to realize or understand that this notice needs to be provided to the individual either in person, by mail, or email, as that individual wants it to be delivered. We can't just say we're just going to hand it to the patient, or we're just going to email it to them. They have to tell us how they prefer to get that disseminated to them. The standard notice of consent, this is that consent to waive your protections as a patient under balance billing. If you don't balance bill, this might be something that you're not going to have to worry about or deal with. But for those of you who do or might do it, this is, again, on that website. It must meet applicable language access requirements. So the form, there is one on the website, and you have to use their language. You have to use it to the T of what they've put in there. You can't change it, with the exception of stuff that's in brackets where you might put in who the contact is or the name of the hospital. That's the only thing you can modify on this consent to waive form. They also want it available in 15 languages, the most common to your area. And that cost is it's the cost of your facility. And then again, what's the timing? And all of this says here, this one is based on hours. The public disclosure form that I talked about just before this needs to be provided no later than when we ask for payment. But we can ask, if we're asking for copay, that can considered payment. And that if you are asking for copayment on that, you're supposed to give them the form every time. Here I put in the Louisiana top 15 languages, and I've noted the citation of where I obtained that information from. So that's something that can be used. And this is just the form. It's the surprise billing protection form. This is what it looks like. It's basically telling the individual that, what the purpose of the document is for, that you're not required to sign this. And if they don't sign it, you cannot balance bill them. There are some situations too where, say there's only one provider and there is no other option for them to get that, have that service provided at your facility, except by that one provider who's not in the network, and there's no other way for them to get that service. That's an exception where you still can't get the balance billing even if they do sign this form. This is where part of the form where you have to then, before of course you're going to sign off on this, the patient needs to understand what the estimate is of what they're going to have to pay out of pocket for this service. And this is where, by signing this, it's basically telling them that they are waiving their rights under this protection provided through this Surprise Bill Act. It has an area for the patient to sign, and then a section for if there's a guardian as well. So that's part one. Part two, I already talked about when that was issued in the Federal Register, but this is where we've heard, if you hear about the good faith estimate, This applies to uninsured and self-paying. And I not self-pay, self-paying. So I'll describe what that is. So here it says there's some other specific or different requirements that are part of this rule that went in effect on January 1st of 2022. One of the things is, as it relates to the good faith estimate, you might have heard terms like the convening provider, the convening facility, or co-provider or co-facility. And not only are we to do the good faith estimate for what's happening at our facility, but we're supposed to find out if there's maybe some other providers involved or another facility involved. We have to get that information and include that on the good faith estimate. Now, it's the law as of now, and it's effective the first of the year. However, what I'm saying here, where it's not focused per se on that requirement, CMS can't come right out and say, well, we're not going to look at that this year. But they've sort of said that, we use this year of 2022 to figure out the logistics around that process. We will start looking to see how compliant facilities are starting in January of 2023. I mean, people have been interpreting that to say, well, it doesn't apply in 2022. It applies. They're just not actively enforcing for it. So use this as an opportunity to get that process figured out and how it's going to work at your organization and how are you going to get that information. It also defers enforcement of the requirement that plans and issuers must provide an advanced explanation of benefits. Now, that they're giving them time at the health plans to figure that out. Now, wouldn't that have been nice had we had that information, which really is what is going to tell the patient what their out-of-pocket truly is going to be. But we had to do price transparency to help with that. And now we're doing some of this other stuff with these good faith estimates. And if they're going to have a procedure done that qualifies under that waiver form, giving them an estimate. So more to come on the advanced explanation of benefits from the health plans. We still need to provide the good faith estimate, as I said, to individuals if they're not enrolled in a plan or have health insurance coverage, considered uninsured and self-paying. So what do I mean by uninsured and self-paying? So uninsured is kind of obvious. They don't have health insurance. They're not covered on Medicare or Medicaid. They truly are without health insurance coverage. Now, the self-paying, what we mean there is those are people who have insurance but choose not to submit or not to utilize their health insurance. This might be somebody with a high deductible plan. Maybe they don't want to go through that because it'd be cheaper for them somehow through that, however their plan works. The key is if they don't, those types of people who are considered self-paying, if they later on submit and say, you know what, I'm going to use my health insurance, they then are not able to protest what the charges are through this patient provider dispute resolution process. There's another category of patient that falls into this uninsured and self-pay, and those are individuals that are enrolled in a short-term limited duration insurance. That's like people who maybe they got off, they just for some reason don't have health insurance that they used to have, and maybe they go on one of those exchange programs till they get to their next job, or they get another thing where they get insured. That's what short-term limited duration insurance is. So the requirements of the good faith estimate is that it needs to be clear and in understandable language. The expected charges for furnishing the items or services need to be identified. They need to include any items or services reasonably expected to be provided in conjunction with the scheduled or requested service. And then those that are reasonably expected to be provided by another healthcare provider or healthcare facility, that co-provider, co-facility I just mentioned, and include the expected billing and diagnostic codes. This one is based on business days. And so there's timing around, no later than 1 business day after the date of scheduling or requested. Here's just a whole bunch of new definitions and terms. I've talked about some of these things already. One thing I do want to mention is the one about expected charge. The expected charge is your cash pay rate, or the rate established by a provider facility for an uninsured or self-paying person, reflecting any discounts. And if you are a 501c3 nonprofit facility, that needs to reflect any sort of financial assistance policy discounts as well. The requirements that are noted under that 501R 4 through 6. So any adjustments that would be applicable there that need to be factored into that cash pay rate. And here we've identified the good faith estimate not only applies to those same 4 types of facility types that I mentioned, but it also applies to rural health centers, federally qualified health centers, lab, or imaging centers, if licensed as such by the state and local law. This is right off of that website, the cms.gov, no surprises. This is some notice that needs to be again posted out there so people understand if you don't have health insurance, you have the right to receive a good faith estimate. You're supposed to receive a good faith estimate in those situations, and just more about that. And the key here is if you receive a bill and it is more, at least $400 more for any provider or facility than what your good faith estimate says, you can dispute that bill. And that's under this patient provider dispute resolution piece. If they're substantially in excess of that and they've requested a self-pay good faith estimator and well, they later submit to insurance, as I said, that person is no longer eligible to do so under this patient provider dispute process. This slide just has a lot of, if you want to dig deeper into these terms, I have the page numbers of where to find that information in the Federal Register. I'm not going to talk a lot about this independent dispute resolution process because some of that stuff's changed now, as you saw from that lawsuit. But at this point, something to think about. Are you ready for the No Surprises Act? This is something that's similar to price transparency. It's not one and done. It's an evolving thing. Do you have a plan for compliance? Do you have some sort of a governance over this process? Maybe it's including the price transparency piece as well. Who's responsible for it at your organization? And step one is you're listening to this and you're trying to understand the requirements of the rules and the regs, but what's the plan for that going forward? And then do we have a work plan to maintain compliance and work towards compliance? And just some high level, some sort of a checklist that I put together. I said this, understanding the state and federal requirements. And then do we have everything we need on our website? Do we have all these disclosure notices and the things that we need to post? Are those all prepared and up at our facility? Contracting, has there been some discussion maybe that, well, now we're seeing that maybe we should be in network for some of these, more so if we have some providers we're billing for, that weren't in the network, might that be something that they want to contract with? Financial implications, are we seeing trending down if we did do balance billing? And we're not doing that in some of these situations, how is that impacting our financials? Again, tracking the updates and understanding, what part 1 and 2 and the price. I bring price transparency up because that's something that annually needs to be updated. And then, tracking, there's things out there that we know are coming up and coming that relate to the health plan. So the insurers have a price transparency rule where they need to put out a machine readable file. And so that'll be interesting to see what that is and how those look on those websites. We have to do that as hospitals, have that machine readable file. So it'll be interesting to see what that is. And also that they need to have some sort of price estimator tool as well. And you see the dates there, July of this year and January 1st of 2023. And then there's something about good faith estimates for insured patients with the advanced EOB, which that still hasn't been determined. And then I just have some policies and procedures for us to have out there, the model around the model disclosure, the physician agreement thing that I mentioned earlier about, do we need to look at our physician agreements? What's our policy around that? Do we need to incorporate the standard consent thing? Do we have a process around post-stabilization once somebody's not emergent anymore and we find out that they're not in network? And what's the billing process for the non-waived types of services? And then the whole process around the uninsured and self-paying good faith estimate. So with that, I will stop. And if there's any questions.
All right, thanks, Amy. So if anyone has any questions, please go ahead and pop them into the Q&A box and we'll read those out. We'll just give everybody a minute to type their questions in. Okay, not seeing any questions, we will go ahead and wrap up. So thank you so much for this presentation, Amy, and thanks everyone for joining us. Please remember to complete the post-webinar survey that should pop up in your browser after you exit. The recording of the webinar should be available on our website within the next couple of days. And as always, please feel free to reach out to us at LRHA if we can be of any assistance to you. And thank you guys so much and have a wonderful afternoon.
Thank you.